I'd like to invite Dr. Lonnie Zwaigenbaum to join us back at the stage, and he's going to speak to us about when to consider medication use.
Thanks, Laura, and thanks, Monica and Susan, for a terrific talk. We had actually sort of changed the order of these presentations sort of on further thinking, because I think probably the main message of my presentation is medication may have a place, but it's really sort of as a backup or adjunct to sort of thoughtful behavioral analysis and management strategies, and sort of empowering families to be able to do that kind of practical problem solving and really come up with positive behavior management strategies. I will talk a little bit about medications for, when might we consider it, sort of how might it be helpful, what are the kinds of factors that might go into making an informed decision in terms of potential benefits and also potential risks, and just also some of the limitations of just sort of what we know about medication options for children with autism, particularly for very young children. So we do, as clinicians, have a somewhat conflicted relationship with medications. We recognize that in certain scenarios, medications can be helpful for particular symptoms. We also recognize that medications are associated with certain risks, and that they're also very commonly used for individuals with autism. There are a couple US-based studies that are listed here. The first one by David Mandel is quite interesting, both in terms of the total number of individuals with autism on some sort of psychotropic medication or medication that's being used for behavior or mental health, and just sort of how the numbers increase over the lifespan, all the way up to 73% by the time individuals with autism reach early adulthood. And interestingly, more common in children in rural areas and in foster care, and likely not just because of sort of severity of concerns, but perhaps also because of access to thoughtful behavior management. And that can be a bit of a marker of concern when we're seeing lots of kids that are being treated with medication as sort of the primary strategy. I think the second study makes an important point that not only are medications commonly used, but once individuals with autism are placed on a medication, they're rarely withdrawn. So it's a big decision. Sometimes we sort of articulate that maybe we will try a medication for a short period of time to sort of relieve some of the intense symptoms while we work on behavior management. But I think it's also important that we acknowledge that often once medication is started, it's difficult to sort of change track. So it has to be a very considered decision. We have a conflicted relationship with medication, and certainly families also often feel it's a very difficult decision to sort of take that step, and it needs to be a very informed decision. I don't have a slide on it in the presentation, but one of the benefits of being part of the Autism Treatment Network is access to a number of really helpful resources and toolkits. And on the Autism Speaks website, among a number of other parent toolkits, there's one about making decisions about medication. And I think that, along with the theme of the day, it's really important to feel like you're in the driver's seat and very much empowered to be making the informed decision, rather than simply sort of follow what's, kind of what is kind of coming down from the physician. And really taking into account sort of the potential benefits, the potential risks, what are the specific target symptoms, and how are we going to evaluate whether it's helping or not. And I think what any kind of treatment strategy, particularly a biomedical treatment strategy in autism, whether it's medication or a special diet, I think really having that kind of clarity about what the goals are, over what period of time will it be assessed, and sort of feeling like what criteria will be used to decide whether to carry on or to shift gears. At this point in time, even in 2017, medications are very much to treat specific behavioral challenges in autism rather than the core symptoms of autism. As we're learning more about the biology of autism and getting a better sense of genetics and brain functioning, there are some interesting ideas and options under development that perhaps will ultimately target some of the core symptoms. One of the things that's been in the media has been the use of oxytocin, which is interesting. I mean, is a hormone very important through the birthing process. It's actually an affiliative hormone that is sort of related to regulation of kind of social emotional behavior. There have been these sort of initial kind of interesting, promising trials that in the very short term, having a little nasal spray of oxytocin can help some adults with autism be more perceptive around recognizing facial expressions in others. But it's very early days, and we really do not have any medication options that we can offer clinically that really make a fundamental difference in someone's autism symptoms. So really we're looking at other symptoms like hyperactivity or aggression or sleep challenges rather than the core symptoms of autism. And I think that as physicians in particular, we're learning to follow the lead of our psychology colleagues to take a more careful evaluation approach, sort of understanding what drives behavior, what are the other strategies that can be helpful before moving to medication. Among the most common symptoms that are treated with medication in individuals with autism are sort of aggression or irritability, and that extends to self-injurious behavior, inattention, hyperactivity, anxiety and mood, which Monica and Susan spoke about. And as I'll comment, you know, it's great that we have some specific strategies in terms of relaxation and managing anxiety-provoking situations. Because the truth is, we actually don't have great medication options for these types of symptoms. And it's interesting that as more and more research is done in this area, there are certain symptoms like inattention and hyperactivity where it actually seems quite promising that we can offer some benefit through the use of some medications in certain scenarios. Whereas the more research we do on anti-anxiety meds, it actually seems less promising that those medications, which seem helpful for individuals who don't have autism and also for adults, that they don't actually seem particularly effective for younger children with autism. And then also sleep problems, which are certainly among the most common challenges experienced by children and families. And of course, it does become a bit of a vicious cycle that when a child or a family is not sleeping well, you know, it's harder to cope with the stresses of day-to-day life, and it does become a bit of a vicious cycle. This like super complicated slide comes from one of the consensus papers coming out of the Autism Treatment Network about approach in managing irritability and aggression. And the bottom line here, this sort of main section here is really much more about doing the careful behavioral assessment that Monica and Susan described in terms of identifying potential triggers, issues around functional communication. So is the child's distress coming out behaviorally because they don't have other ways of communicating that? Are there underlying medical problems? So certainly one of the challenges faced by individuals with ASD and their families when the individual has difficulty communicating verbally is when they're distressed, but also when they're in physical pain. It's very difficult for them to express it other than by becoming irritable and agitated. And making sure that we're addressing things like abdominal pain and headaches and reflux, and just making sure that we're taking into account, could a change in behavior be an expression of a physical health symptom? And really, it's not until we've gone to that process that we start to consider medication. However, you know, all of you in the room also recognize that there are some situations where an individual's behavior, particularly aggression or disruptive behavior, is so extreme that it really does affect the individual's opportunity to learn, to be in a group setting like school. It's a huge impact on family life, and that's where medication may offer something helpful. So there are a number of medications that have been studied quite extensively in children with autism. Really the best research designed for studying the effect, particularly of a short-term biological treatment like this, is a randomized controlled trial where you have some individuals receiving the treatment, other individuals receiving an alternative treatment, whether it's a placebo or just a different treatment, and seeing whether the group that received the medication are actually benefiting. So there is a group of medications that are broadly described as the atypical antipsychotics, so pretty heavy-duty medications. That includes risperidol and Abilify, that genuinely do reduce irritability, reduce aggression, but are also associated with significant side effects, particularly weight gain, can actually affect glucose tolerance, can affect body cholesterol. So long-term, these side effects can be quite significant. Interestingly, for some individuals where the aggression is associated with severe hyperactivity, particularly those individuals who are a bit more verbal and less developmentally delayed, the stimulant medications, you know, generally reserved for kids with hyperactivity, can actually be helpful for this kind of sort of impulsive irritability. There are another group of medications that operate in a different way to kind of reduce physiologic arousal. So clonidine and also guanfacine or Intuniv, where there is some experience using these, especially kids that are sort of highly reactive and sort of become agitated in reaction to stress in the moment. But they also do have potential side effects, including low blood pressure. I think the key point with the antipsychotic medications, which the Risperidol and Abilify, which are probably most commonly used for severe aggression and irritability, is because of the side effects, they need to be monitored in a very careful and systematic way. So there's actually a set of guidelines that came out of the University of Calgary that include both physical examination and in particular monitoring weight gain, also neurologic exam, because some individuals on these medications can develop involuntary movements, which can also become quite disabling, and then also blood work. So for some families, not only is the potential side effects a concern, but just the notion of having regular blood work for the kids, which is actually essential to monitor for these potential side effects. So there's no question that it's a big decision, although for some families, these medications can be quite effective. Just to briefly talk about inattention and hyperactivity, with the new set of diagnostic criteria through DSM-5, there's actually greater flexibility to think about multiple diagnoses in kids. So, one can have a child with autism who genuinely also has attention deficit hyperactivity disorder, very reactive, makes impulsive decisions, which can lead to concerns about safety, very high activity level, and perhaps there may be a somewhat more modest response rate that kids with autism may not respond as consistently as other kids to stimulant medication like methylphenidate or Ritalin, but it can actually be quite effective. I think the kids who tend to respond the best are the kids who are somewhat more verbal and less developmentally challenged, whereas the children that we see with more severe intellectual delays, often the irritability along with hyperactivity doesn't respond as well to this group of medications. And again, we do see the group of medications that's more about arousal, like clonidine and guanfacine, being used as well. So overall, we do see sort of the best response to the oldest medication used for ADHD, Ritalin. There are potential side effects that do need to be monitored. I commented on this. This is a slide about management of anxiety. I think the bottom line here is refer to Susan and Monica. That the reality is that the clinical trials are not really all that supportive of using specific anti-anxiety medications for this purpose, although some individual children may show some benefits. Certainly, considering environmental triggers and developing sort of anxiety management strategies need to be the primary approach. And then finally, sleep problems. And I think one of the things that we've learned about sleep problems for kids with autism is that even though the underlying biology may affect the sleep cycle, for the most part, the sleep challenges experienced by children with autism are similar to those experienced by other children at similar ages. So preschoolers may have trouble falling asleep and staying asleep. Teenagers with autism may be up till the early hours of the night on the internet and then have trouble getting up the next morning and then run into this problem of delayed sleep phase. Again, is an important medical focus on considering physical health factors that may affect sleep. So unrecognized seizures, things that cause pain like gastroesophageal reflux, obstructive symptoms, so kids that have chronic allergies or big tonsils who snore at night, that may also affect their quality of sleep. And we make sure that these physical health problems are addressed. It's interesting that the most effective kind of medication treatment for sleep problems in kids in individuals with autism is actually not even classed as a medication in Canada. It's actually classed as a nutritional supplement, and that's why it's widely available without a prescription. But melatonin has actually been shown to be kind of probably the most effective medication strategy for sleep problems. It does reduce the amount of time it takes for people to fall asleep, and it's really relatively safe. We're not really aware of significant side effects, so there is some flexibility in using it. The challenge, of course, is for children with autism who have disrupted sleep who don't respond to melatonin. Again, the mainstay is thinking about general strategies. So, kind of a consistent bedtime routine, a quiet environment, avoiding things containing caffeine that might keep the kids up. So sort of carefully considering those issues. But melatonin can be an adjunct. And then we're pretty cautious about using other medications because often the side effects are kind of worse than the benefits. So just the bottom line, I think both in thinking as a clinician, but also sort of thinking about decision making as a parent, that medications genuinely are used for symptoms other than the core symptoms of autism. And I think the decision is really, are the symptoms it's not only does the child have some irritability or have some difficulty with sleep, but how much is that impacting on the child's life and the family's life? You know, is that starting to get in the way of their daytime functioning? Is it hard for them to have a positive learning experience in the classroom? And therefore, what are the potential benefits of the medication? What are the potential side effects, and how are we going to monitor for them? And particularly something like risperidol, making sure that we're using the best, kind of the standard approach to monitoring, and that we're doing it consistently. Knowing sort of what can happen, we're very cautious about treating with multiple medications. So rather than just adding one and then a second and then a third, we also always have to be thinking critically about, are these medications actually helping? And if we think about a second medication, really the motivation should be to try to wean the child off the first so that they're on the right treatment. And then I think that there is an important caveat that even the limited evidence that I've spoken about this morning is primarily for school-age children with autism or adolescents, and that there's actually very little evidence for medication management in preschoolers. And we really do have to work carefully and in partnership with therapists and teachers and so on to really think about the behavior management strategies. But in the future, maybe we will have kind of biological options that will address some of the core features. Okay, so thanks very much, and I'll turn it back to Lori.